Hi, my name's Amy Holmes, and this is my Case Connections video for Unit 4. For my video, I chose Case 1 and Case 3. Case 1, as a newborn girl, appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. Patient's labs came back and the initial blood ammonia level was elevated at 314 UGs per DL and rapidly rose to 600 UG per DL. Normal range being between 17 and 80. The urine orotic acid level was markedly elevated at 473 UMOL per liter. Normal level 0 to 3. Plasma citrulline level was normal to low at 10 per liter. Normal levels 12 to 55. The diagnostic test would be plasma glutamine to distinguish between urea disorder and a disorder in beta oxidation. Glutamine is a non-toxic, non-essential amino acid which takes part in the detoxification and transport of ammonia. In the urea cycle, plasma glutamine rise, but are normal in the beta oxidation. A disorder in beta oxidation means a fatty acid oxidation disorder and is also termed as a lipid metabolism disorder that occurs because of deficiency of enzymes that are needed for lipid metabolism. Plasma glutamine tests are utilized to find urea cycle disorders in infants. Blood glucose is not correct because blood glucose levels do not indicate disorders in the urea cycle or in beta oxidation. Disorders in beta oxidation occur due to errors in fat metabolism. Disorders in the urea cycle occur due to mutations in the enzymes that are involved in the urea cycle. Serum fatty acids would not be correct due to it being only useful in determining a beta oxidation disorder, which are not affected by the urea cycle. Thus, they cannot be a diagnostic for a urea cycle disorder. One urea cycle enzyme that is most likely deficient for this case would be ornithine transcarbamylase, OTC. This is an X-linked recessive urea cycle disorder that is characterized in affected boys by very high serum ammonia levels. In affected females, it causes mutation of one of the X chromosomes that can develop hyperammonemia, causing carbamyl phosphate to accumulate in the mitochondria and then leak into the cytoplasm, resulting in raised levels of orotic acid in the urine. One urea cycle enzyme that would be least likely to be impaired would be carbamyl oil phosphate synthase 1, or CPS1. When CPS1 is deficient, there would not be an elevation of orotic acid levels. This would lead us to determine the CPS1 is working and least likely to be impaired. For case 3, is a 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there was no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, so blood samples are drawn and urinalysis is performed. The results for this individual are his plasma urate was 10.5, normal range being less than 7. And his urinary uric acid was 215, normal range being 413 plus or minus 78. I feel the primary presentation of gout in this individual is due to overproduction of purines. There is an increase in substrate glucose 6-phosphate that leads to an increase in ribose 5-phosphate, which becomes trapped in the cell, leading to an increase in the synthesis of nucleotides. Purines are nitrogenous base that are broken down to uric acid, which is then excreted through the kidneys as a component of urine. In the case above, the secretion of uric acid in the urine has fallen considerably from 413 mgs in 24 hours to 215 mgs in 24 hours. Different conditions that lead to the impaired removal of plasma uric acid cause gout. Soft drinks contain low levels of purines and high level of fructose. Fructose is a carbohydrate known to increase uric acid levels by increasing the rate of degradation and synthesis of purine via increased adenosine triphosphate, or ATP, degradation to AMP, adenosine monophosphate. AMP is a uric acid precursor. The patient mentioned during his exam that he had recently switched from diet soda to regular soda and drinks between 4 to 5 liters of soda a day. Primary sugar in most sodas is fructose or high fructose corn syrup. I do not feel that decreased salvage of purines is the correct answer due to failure of the salvage pathway of hypothalene and guanine would be like Lesch-Nyhan syndrome, a decrease in inositol monophosphate and guainosol monophosphate leads to an increase in conversion of 5-phosphoribosol 1 pyrophosphate, or PRPP, to 5-phosphoribosylethamine, which further exacerbates uric acid overproduction. However, there are additional neurological symptoms that are associated with this condition, and since the patient did not present with any neurological symptoms, this would not fit a diagnosis for this patient. Decreased urinary excretion of uric acid would also not be correct for this patient, due to this being caused by excessive alcohol consumption, causing an increase in production of lactic acid and competing excretion of lactic acid and uric acid. This concludes my video presentation for Case Connection Unit 4. Thank you.